Hi, everyone. Welcome. So glad you could join us today. My name is Preeti George, and I am the project director for SAMHSA's National Training and Technical Assistance Center for Early Serious Mental Illness, also known as the ESMI TTA Center. So as you're logging on, I just wanted to welcome you to our webinar on suicide prevention best practices for individuals at clinical high risk for psychosis or those who are experiencing first episode psychosis. So thanks so much for joining us today. We're very excited to present this information to you. So we have a few housekeeping slides to go through. So as people log on, we'll just run through these. So this is our disclaimer slide that the views, opinions, and content that are expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, or CMHS, the Substance Abuse and Mental Health Services Administration, or SAMHSA, or the U.S. Department of Health and Human Services, HHS. So just a few housekeeping notes before we get started. This presentation is being recorded. So during the presentation, you are welcome to submit your questions through the Q&A or through the chat feature. So please feel free to do that. And we welcome all of your chats where you're introducing yourselves. Thank you very much. That's great for people to see who's on the webinar. If you have any questions or need any information, there are individuals who have the name ESMI TTA Center next to their names on Zoom. So feel free to reach out to them if you have any questions or need any assistance throughout the webinar. And also just wanted to let you know, we will be making these presentation slides available afterwards via email. So all of you will be getting an email with the slides attached. All right, so for our webinar today, I will introduce our guest speaker, and she will lead you through a presentation about suicide prevention best practices, specifically for individuals at clinical high risk for psychosis, as well as individuals who are experiencing first episode psychosis. We'll go through the presentation, and at the end of our session, we'll have a Q&A session where we'll go through your questions and then have some closing remarks. So that's what we'll be doing today, and I'm so pleased to introduce today's speaker. So Dr. Krista Labouillet is an assistant professor of clinical psychology and psychiatry at Columbia University and the co-director of the Suicide Prevention Training Implementation and Evaluation Program, also known as SPTI, at the New York State Psychiatric Institute. Her role includes the design, implementation, and evaluation of statewide suicide prevention efforts for New York State, including training of providers and evidence-based practices. She was project director of the largest evaluation of the zero suicide, suicide safer care model ever conducted in outpatient mental health, and has adapted that model for coordinated specialty care for first episode psychosis. Her research has resulted in numerous peer-reviewed publications and book chapters, and we are so thrilled to welcome Dr. Labouillet.
Thank you so much. I'm thrilled to be here as well. All right, so what are we going to do today? Well, hopefully provide some guidance for mental health providers and supervisors on how to implement evidence-based suicide prevention for individuals both at clinical high risk for psychosis or experiencing their first episode of psychosis. We'll talk about the development of how this evidence-based suicide prevention protocol came to be and provide a bit of information on approaches that will hopefully work best with this population for universal screening, assessment, and monitoring, including things like the 988 Suicide and Crisis Lifeline and other resources that we can share. And so first, before we jump into suicide prevention, it's really important just to all be on the same page regarding the definitions for clinical high risk of psychosis. There's multiple different definitions at play. And so depending on how one defines it, different folks would fall into those populations. Some folks are discussing genetic vulnerability as, individuals who have the presence of certain genes or first-degree relatives. And certainly that is a different cohort than folks who have already begun to experience basic symptoms or cognitive disturbances, subjectively experience disturbances in thought, affect, motor functioning, etc. Um, Furthermore, there are folks who consider clinical high risk to be the presence of attenuated positive symptoms. So positive symptoms that experience, sub-threshold severity. So there could be the presence of positive symptoms, but not quite to the threshold that would meet criteria for psychosis. Another definition is this idea of brief or limited intermittent symptoms, symptoms that may meet the threshold of psychosis but that remit spontaneously and are only short-term duration rather than the extended periods typically associated with a episode of psychosis. We also want to clarify that first episode psychosis, when we're referring to FEP, this is going to be individuals who've experienced their first episode of threshold symptoms, folks who actually are meeting diagnostic criteria for a psychotic disorder for the first time. Um, Ultimately, when discussing clinical high risk for psychosis and first episode psychosis, they really vary both in severity of symptoms, but also in terms of time course, with basic symptoms typically appearing earlier in the time course, then progressing to attenuated positive symptoms and brief limited intermittent symptoms prior to the onset of the first threshold episode representing FEP. Regardless of the definition that we are using, this period of clinical high risk is an opportunity for prevention and early intervention. And the FEP period also represents an opportunity for early identification and treatment. And why is this important? Well, that can improve the psychosocial trajectory of very vulnerable individuals. We know that a longer duration of untreated illness is associated with greater negative outcomes. And so the sooner we can identify and assist folks, hopefully the better the outcomes, the better their trajectory will be. This is particularly critical given what we know about suicide risk for individuals with psychosis. Individuals diagnosed with a psychotic disorder have a nearly 5-time increase in deaths by suicide. 25 to 50% of individuals with psychosis attempt suicide at some point in their lives. Somewhere between 5 to 13% die by suicide. And we know that the highest risk for suicide is during these early stages, during illness onset. Um, Suicide risk for young people at clinical high risk of psychosis or experiencing their first episode is 2.7 times higher than for older adults diagnosed with a psychotic disorder. There really seems to be something about this initial transition, the experience of having psychotic symptoms for the first time, before folks are properly connected to treatment, before folks really know what's going on, that really puts folks at really high risk for death by suicide, with 8 to 10% of individuals experiencing their first episode of psychosis making a suicide attempt during that period. And so we know we are speaking of incredibly high risk individuals. And so this is why, really having an evidence-based model is going to be so important. Now, when we're discussing suicide risk, I'm going to be talking about suicidal behavior more broadly. So this is going to be any action that's taken towards ending one's life. Certainly, suicide attempt is the most commonly thought of suicidal behavior, but we also want to be aware of folks engaging in preparatory behavior, such as obtaining access to means or writing a suicide note, or things like interrupted attempts, where somebody may begin to move towards making a suicide attempt, but could be interrupted either by themselves or others. Of particular relevance when working with individuals experiencing psychosis, we also want to think about the possibility of unintended self-harm. Um, And so this is when an individual engages in potentially dangerous behavior, and they may not have the intention of ending their lives, but as a result of their psychotic symptoms, they could be engaging in behaviors that are actually quite dangerous and could result in serious injury or death. So this is as a result of psychotic symptoms, not necessarily because they want to end their life. So this could be things like jumping off of a building due to a delusional belief that they're able to fly, or having hallucinations that say that hurting themselves is the only way to keep their family safe. So this is a little bit different than a suicide attempt where a person is actually intending to end their life. And many of our traditional approaches of assessing and screening for suicide, might not catch these things where delusions or disorganized behavior could potentially lead to equally dangerous behavior in a person's life. So, when we are talking about suicide risk amongst folks experiencing clinical high risk or first episode psychosis, we're actually probably going to be talking about both of these things today, both this risk for death by suicide, but also this risk for death by unintended self harm that can result from psychotic symptoms. The earliest phase of psychosis is a particularly vulnerable time for these behaviors. And there's a number of reasons for that. Certainly folks who are early in their psychosis trajectory, they probably have not yet been prescribed effective medications. The escalation of their psychotic symptoms can be very frightening. This can lead to dangerous behavior. And many times folks experience an intense desire to escape these intolerable symptoms. They can produce agitation, panic. And then when folks are starting to move out of that first episode of psychosis, many times they're incredibly overwhelmed. Thinking about the consequences of what happened as in the aftermath of their behavior, in the aftermath of the things that they did or said that occurred while they were experiencing their psychotic episode. This can lead a lot of folks to feel very hopeless during this period, especially before they're connected to care that can really provide hope for their recovery. In addition to these early psychosis specific risk factors, there's also a number of traditional risk factors that are highly prevalent in this population. So we know that, there is a high overlap for folks experiencing clinical high risk or their first episode with behaviors like non-suicidal self-injury or previous self-harm behaviors, substance misuse. There's a number of comorbid mental health conditions that tend to present with both conditions. And many of the risk factors that we would consider for suicide risk amongst any population, things like trauma or sleep disturbance or hopelessness, are particularly prevalent amongst folks that are at clinical high risk or experiencing their first episode. Now, the sad thing is that despite knowing all this, despite knowing the high overlap between suicide risk and psychosis risk, and knowing that folks that are experiencing clinical high risk are at such high risk for suicide, despite this high risk, most suicide prevention best practices were not developed with or for persons at risk for psychosis. Typically, these models were developed in standard outpatient settings, often with folks with mood or anxiety disorders. And so, interventions for suicide prevention in early psychosis are actually quite understudied. The majority of our evidence-based prevention protocols do not typically include guidance on the important adaptations that are needed for individuals experiencing first episode psychosis. And so that's what we're hoping to talk about today. What adaptations are truly needed to have an evidence-based approach to suicide prevention best practices for individuals at clinical high risk for psychosis or experiencing their first episode of psychosis. Traditional evidence based models for suicide suicide prevention, things like the zero suicide model, tend to follow an assess, intervene, and monitor approach. So this AIM model for suicide prevention has a lot of empirical evidence that really our interventions for suicide prevention, particularly in outpatient settings, but really across all behavioral health settings, really do fall into these three main categories of assessment, interventions, and ongoing vigilance and monitoring. So that's going to structure our conversation today, how we take this AIM model for suicide prevention and make those critical adaptations for individuals with clinical high risk or FEP. So we'll start with assess. Really, there should be universal screening and assessment procedures that everybody in an outpatient setting is receiving, but particularly due to the heightened risk for suicide and unintended self-harm amongst this population, universal screening and comprehensive risk assessment are going to be critical. Everybody in behavioral health settings typically receives screening for suicidal thoughts, but they may not necessarily be receiving universal screening for unintended self-harm. Ideation that could be driven to engage in behaviors that maybe other people think are dangerous, but they don't think are dangerous. They think are, driven by, the delusions that they're experiencing. The vast majority of people are not going to spontaneously self-report this without us integrating universal screening procedures. And so we know that our typical suicide screening tools are often insufficient in assessing for unintended self-harm. And so we need to take additional approaches to make sure that this is integrated into our procedures. What are some important components for approaching risk screening and risk assessment for early psychosis? Well, first and foremost, being a good clinician, we are not going to encourage disclosure with our patients, especially about really challenging things that we're speaking about. Things like suicide or psychotic experiences are not easy to talk about, especially with somebody that we're new with, somebody that is potentially a stranger. We really need to first and foremost really focus on building rapport, being collaborative, joining with this person, meeting with them where they're at, focusing on that recovery-oriented, client-centered approach, because that relationship is really going to drive the quality of the information that we receive. It's going to be really important that we're adopting a direct, matter-of-fact style when asking about suicidal thoughts and behaviors, asking about unintended self-harm. We don't want to put the burden on our clients to spontaneously address these things and bring them up. They really should be something that we should be talking about with everyone. Particularly when working with psychotic participants, it's really important that we provide a rationale for why we're doing these things. Sometimes folks can be experiencing paranoid symptoms. They may have not, received these kind of services in the past. And so it's going to be really important for us to be transparent in why we're doing the things that we're doing, how we're going to use this information. And we need to be prepared to break down these concepts. Sometimes this takes a little bit longer than the standard intake, but as much as we can to make sure that the individual really understands our approaches, and if we can also get additional collateral information that may flesh out our assessment approaches. Again, for everyone coming into our behavioral health settings, it's really important that we include questions about unintended self-harm in addition to just screening for suicide risk. So an example that we used in our coordinated specialty care clinic was just asking if at any point in their life they've had thoughts of doing something where other people thought it might be dangerous, where you could get hurt without meaning to end your life. So certainly folks may be explicitly experiencing suicidal ideation. But there's other times where they thought they were fine, but other people were really concerned about the dangerousness of this behavior. And so just having that conversation, having a dialogue with people without assuming that it's suicidal, can help us approach things where maybe these behaviors were quite dangerous, but driven by other reasoning. Ultimately, when it comes to working with folks at risk for psychosis, it's going to be increasingly important that we do a really thorough, comprehensive suicide risk assessment. Many times, these individuals do not ping on our standard screening tools because they're not thinking of their thoughts or behaviors as being explicitly suicidal. And so, if somebody is denying recent suicidal behavior or recent suicidal ideation, this does not necessarily mean that they're not at risk. We really need to do a good job of getting a broader case conceptualization. And this is really where comprehensive suicide risk assessment comes in to optimally determine risk. For those who aren't disclosing or endorsing ideation, only a comprehensive assessment is really going to detect their elevated risk. Ultimately, it's really important that we're doing this because not all clients are going to be willing or able to disclose their thoughts. And even those who may not be experiencing those thoughts today could be one acute stressor away from having them tomorrow. We know that risk fluctuates over time. So screening and assessment must be ongoing. This is not a thing that we just do at intake and never do again. This really needs to be happening at a regular intervals throughout our interactions with folks so that we can maintain vigilance for the presence of suicidal thoughts and behaviors. When I'm referring to a comprehensive suicide risk assessment, I really mean assessing all categories of risk and protective factors, not just engaging in suicide screening where we're asking about ideation. The reason for this is that information about folks' background and family situations and environmental situation, both historical vulnerabilities and current ones, this is going to help providers to anticipate crises and establish measures to maintain safety. This is going to help us make better shared decisions with our clients about triage, about treatment planning, and really, it's going to guide our focus to work with clients to reduce modifiable risk factors and enhance their modifiable protective factors. Um, when we're working with individuals at clinical high risk or experiencing first episode psychosis, we really need to recognize that none of our clients are going to be at low risk. All individuals at risk for psychosis or experiencing psychosis are at elevated chronic risk relative to the general population and relative to other mental health populations. But unfortunately, that's not always a great predictor of who's at highest risk and needs support right now in the short term. And so it's often recommended to avoid the standard high, medium, low risk determinations and really focus more on acute risk. This recognizes that all individuals with psychotic symptoms are at some degree of risk, but we can really focus more on what their immediate needs are by thinking of whether that acute risk is currently elevated versus not currently elevated. And these are inherently more flexible categories that folks move in between. Our folks that are at not currently elevated risk are going to have few proximal or acute risk factors present, and no real acute warning signs of either suicidal ideation or uncontrolled symptoms of psychosis that may lead to self-harm behavior. These individuals will have strong protective factors, and their symptoms are well managed. That's not to say that this could not shift over time, but in the moment, while these folks are still at elevated chronic risk for suicide, their acute risk of acting in the short term is much lower. Now, for our folks that are at currently elevated risk, these are going to be the folks who need additional supports. So they may have numerous, proximal risk factors or warning signs for suicide or unintended self-harm, where the risk factors are really outweighing the protective factors. The protective factors may either be absent or really not prominent in these scenarios. There may be suicidal ideation with intent. There may be unintended self-harm ideation or recent unintended self-harm behavior. And these are individuals who have access to means or could easily obtain access to means where we may be worried about them acting on their urges. There could be presence of other psychiatric symptoms that could be contributing to the scenario. So recent changes in terms of increased substance use or agitation, sleep disturbance, things that put folks at increased risk for dysregulation. There could be the presence of recent traumatic events or victimization or shifts in care, recent or anticipated life stressors, things that we know that elevate risk for everyone, but that are particularly relevant when talking about a vulnerable population like those with psychotic symptoms. We also want to be on the lookout for the presence of first episode specific risk factors, things like command hallucinations or delusions that could be increasing the likelihood of dangerous behavior, severe disorganization that could lead to the risk for unintended self harm. We know sometimes when folks are experiencing their first episode, they haven't yet developed coping skills for addressing these things. They haven't yet necessarily engaged in treatment that's going to help them with these things. And so they may be at increased risk for erratic behavior or significant distress. And as they begin to come out of that first episode, frequently the shame or hopelessness, fears that they're going to be a burden, can be big contributors to suicide risk. These individuals, when we're seeing a number of these risk factors present, are going to be the individuals that we're really considering at currently elevated risk who may need additional supports. And so, what are those interventions going to look like when we're talking about supports? Well, there's probably some interventions that everyone with psychotic symptoms would benefit from. Psychoeducation is a big one. We really want to provide information to all individuals in our treatment and also their family or supports, if we can, about the warning signs of suicide, the warning signs of unintended self harm, how this risk fluctuates. Many times, folks are very frightened by the onset of these symptoms. They're not quite sure what it is. And so, we can be an important resource in helping individuals recognize their risk, helping individuals recognize how to cope with these behaviors and experiences. Um, and really helping their supports as well, to understand what things are needed to prevent crises and help them maintain safety. One way that I do this is that I provide crisis information to all of the individuals who come to me for services. We provide crisis information to all individuals, all of their supports, regardless of whether their risk is currently elevated or not currently elevated. These could be helpful contacts like your clinic's emergency number or the location of local psychiatric emergency programs or crisis respite, mobile crisis, things that could be available in their community that, hopefully they don't need it. But if they do, that way they know that these resources exist, they know where to go. Another thing that I always refer to is the 988 Suicide and Crisis Lifeline, letting folks know that this is a 24/7 available service that anyone can access. Um, Other things that folks experiencing psychosis may benefit from: case management. Many times, these individuals are in financially unstable situations, experiencing housing instability, food instability. Sometimes, something as simple as connecting them to case management to help with some of these social determinants of health can make a critical difference to a person's suicide risk. It also can be very helpful to engage additional supports. So, engaging family members, engaging other supports in their lives can help create a broader safety net, can help an individual to maintain safety in a less restrictive environment. When available, integration of peer specialists is an incredibly powerful thing for individuals experiencing psychosis. Peer specialists has such a valuable role in recovery-oriented care by being able to inspire hope, by validating these experiences in a way that maybe us clinicians can't because we may not have been there personally. Peer specialists can really provide instrumental and emotional emotional support in navigating the difficulties of the healthcare system. They can talk about what coping skills and reasons for living have worked for them and really serve such a vital social connection. And so the integration of peer specialists more into our behavioral health settings can make such an important difference for individuals experiencing psychosis. Um, One thing that we focus on very actively in our coordinated specialty care programs is the development of distress tolerance and coping skills. We know these skills help both with psychotic symptoms and with suicide risk because they improve the quality of life, they improve individuals' ability to manage their mental health crises, and many times they allow folks to really pursue social, academic, occupational goals, achievements that serve as reasons for living for them. Things that are vitally important to their goals for life are keeping them tethered to life, keeping them, wanting to live to, because many times when folks first receive a psychotic diagnosis, they feel as though these things are all going to go away, that they may never get to go to college or be married or have children, things that are critical to their view of the future, and allowing folks to realize that recovery is possible for them, and that they can still achieve their goals are critical reasons for living for the majority of our patients. So, what would universal monitoring look like? What should everybody receive? Even for our low risk individuals, we really should be rescreening all individuals frequently, at least quarterly, whenever our clinical judgment pings. We really want to be checking in regularly because just because somebody didn't have suicidal ideation or self harm ideation when they entered our clinic at intake doesn't necessarily mean that it couldn't develop throughout the course of treatment, even when somebody is doing pretty well in terms of their treatment. We really want to give all individuals an equal opportunity to disclose. And sometimes it can be hard to maintain that ongoing vigilance throughout treatment. We really need to make sure that while we're making progress on our clients' other goals, we're also checking in to make sure that they're still safe. If there are high risk periods, things like shifts in care or large life stressors, we really want to make sure that we're increasing clinical contact during that period. So, if somebody has recently been discharged from the hospital or experienced an anniversary or a large life stressor, we want to make sure that they have access to greater support during those times. So that's really the stuff that we're hoping that everybody experiencing psychotic symptoms could receive, regardless of their risk level. For folks that are at elevated risk, for currently elevated risk, we certainly advocate for safety planning. Most of you are going to be familiar with safety planning. This is an intervention that results in a written prioritized list of coping strategies, sources of support that are really designed to help prevent or de escalate a mental health crisis. Usually, this is used for suicidal crises, but certainly safety planning can be modified to address dangerous symptoms of psychosis, unintended self-harm, or and include FEP-specific warning signs that could be used in a way similar to psychiatric advance directives. We really want to be helping folks to cope ahead, problem solve ahead for crises that could occur, and engage in, counseling on access to lethal means, to focus on family and social support involvement, so that we can gain the additional support that these individuals need. Um, when we're working with folks who are at currently elevated risk, we want to make sure that self-harm is a treatment goal, that we are making sure that there are specific treatment planning going on to reduce the risk for self-harm. Just treating the underlying psychopathology like psychosis or depression does not necessarily mean that the suicide or unintended self-harm risk will go away. And so we want to focus on developing goals and treatment targets that will address these things directly. As always, we want to reach shared decisions with the client and ideally with their supports as to how to approach this. But oftentimes, directly targeting suicidal thoughts or unintended self harm thoughts by reducing risk factors and drivers of these thoughts, or by enhancing protective factors and reasons for living, are good ways to really focus our suicide specific treatment planning. In terms of interventions directly, individuals who are at currently elevated risk, we really want to make sure that we're increasing our clinical contact. Now, this could take a number of forms. This doesn't necessarily mean you, as an individual clinician, needs to be, seeing them multiple times a week, but it may be that they're going to need more frequent sessions for a little while, or sessions that are longer in duration. Maybe we need multiple contacts. If we're operating in a system that has a multidisciplinary team, maybe multiple members of the team could connect with this person. Sometimes folks may need home or community visits as well as office visits, or at least more frequent planned check-ins. Maybe there are times that we're meeting in person, but there's also additional between session contacts, whether that's via telehealth or phone or text. We certainly want to encourage participation in other supports, things like group therapy or support groups, outreach to family and other supports, and really making sure that prescribers that are working with these individuals are also cognizant of their self-harm risk, because they could potentially alter their prescribing practices to include things like clozapine, or switching to long-acting injectables that may reduce the potential for self-harm. When we are monitoring individuals that are at currently elevated risk, we really want to check in about suicide and self-harm risk at every single session. Again, this doesn't have to be very strict, very formal screening. It really should be more of a clinical interaction that occurs in a conversational manner. But we want to make sure that we're engaging in weekly check-ins about any concerning or important symptoms, the same way that we would be checking in about things that we know have been on their mind. We really want to be checking in if somebody is in an acute high risk period. We want to be asking about suicide and unintended self-harm every time that they're coming in. If they're not coming in, if they experience a no-show, we really want to make sure that we're doing outreach as well. We know that folks at risk for self-harm are at particular risk during breaks in continuity of care. So if somebody misses an appointment, it could be because they forgot, or it could be because something's going on with that individual. And so it's going to be increasingly important for those folks who are in these high-risk periods that we're doing outreach. We're using, a structured follow-up and monitoring approach is recommended. This doesn't have to be like a full phone session or anything, but just calling to reach out, make sure they're okay. And then, if they are struggling, we can really help by, doing things like reviewing that safety planning or connecting them to the services that they may need before we do things like, make sure we're rescheduling the session and all that. This is really important for both maintaining their safety, but also for, maintaining that treatment engagement and motivation for care. So, what are our general recommendations? Well, you may have noticed by talking about this, care for individuals at clinical high risk or experiencing their first episode. This often includes several approaches that are not typically provided in outpatient behavioral health settings. Things like case management or care coordination services may not be standard in our behavioral health settings. Not every place has multidisciplinary teams or peer support. And sometimes that frequent clinical contact and monitoring of high risk can be difficult in our standard settings where we may not be seeing people that frequently, or we may not be used to always engaging family and other supports in treatment. Um, this is where, some of our regular outpatient behavioral health settings may need to provide additional supports to really keep those at risk or experiencing early psychosis safe during these dangerous periods of high risk. What we know is that even amongst coordinated specialty care programs designed for first episode, Psychosis. What works is not always systematized, even for programs that offer all of these things as part of their multidisciplinary model. A lot of times they're not systematized across programs. There could be substantial variation in procedures between and within programs. So taking a quality of improvement approach, making sure that folks are receiving the services they need, and that services are being received with fidelity is going to be important in all of our settings. Ultimately, even excellent programs can benefit from more emphasis on upstream prevention, family engagement, coordination of care, additional training for clinicians in risk assessment, safety planning, trauma-informed care, approaches that are specific to psychosis, things like cognitive behavioral therapy, or adaptations like dialectical behavior therapy principles can be really important for folks that are working with psychotic populations, and maybe we're not necessarily trained in all of these approaches and their adaptations for psychotic populations. Um, Lastly, when working in multidisciplinary teams, having role-specific guidelines is also very important. Many times things like assessment fall to the primary clinician, but if we have a multidisciplinary team, there may be slightly different roles for prescribers versus clinicians versus employment specialists or peer specialists. And so making sure everybody on the team is clear about their role, but that everybody has a role in suicide prevention practices. So, in summary, we really need more training and nuance in our screening and risk assessment approaches across our behavioral health settings. Many of our settings require screening for suicide risk, but our standard measures, even good ones like the Columbia Suicide Severity Rating Scale, are really not enough to detect risk for individuals at risk for psychosis. There needs to be greater awareness of psychosis specific risk factors, as well as the traditional risk factors that are particularly pertinent for these populations. We also need to be aware that risk assessment needs to be ongoing throughout treatment. This is true for everyone, but it is particularly true for individuals whose psychotic symptoms may be emerging and evolving across our times in treatment. We really need to maintain that vigilance so that we are aware as folks' experiences are changing. Ultimately, this means that relationship building is vital. Without good rapport and trust, our clients are not going to feel safe to disclose their symptoms. Ultimately, helping individuals at risk for psychosis is going to need to focus on the development of protective factors and reasons for living. This is integral to building a positive approach to prevention services and recovery oriented care. So often, folks hear the word psychosis and it sounds like this terrible, terrible thing. It sounds like the erosion of their future, and that doesn't have to be the case. Ultimately, these experiences can be frightening, but folks can live wonderful, fulfilling lives while hearing voices. Folks can recover and go on to achieve their goals and dreams. And so we really need to help folks recognize the protective factors and strengths that they bring to treatment and prevention services and the reasons for living that they either currently have or can stand to develop. Different roles and team members are going to have varied but equally important skill sets to share in terms of this focus on recovery oriented care. And so making sure that we're framing individuals' educational and occupational and social goals as reasons for living is going to infuse suicide prevention throughout all of our discussions of client centered goals. Ultimately, suicide prevention has to be the bedrock of recovery oriented, client centered care. We need to help folks, we need to empower folks to develop mastery over their symptoms. This is going to promote recovery. Although individuals may have many, many goals for their treatment, keeping them safe, has to be the primary concern, and it can't take a backseat to educational or occupational attainment. Safety must be maintained. They need to live, they need to be well in order to achieve their other goals. And so ultimately, as providers, we need to maintain vigilance regarding suicide and unintended self harm prevention throughout the course of our treatment. Got some references that we will share. But I will wrap up there with my contact information because I know this was a lot of information. I'm always open to questions, both ones that we present here today, but also I am always an email away should somebody have questions, once this session is concluded as well.
Thank you so much, Dr. Lavalier. This was very, very helpful. There was a lot of rich information that was very useful, I think, for many of us that are working in clinical and research settings related to suicide prevention in these populations. So thank you so much for this very rich presentation. So on your screen here, you can see that there is a webinar feedback form. So if you would like, you can click on the QR code. Also in the chat, there is a link to the same feedback form, and you can provide any comments and give us feedback about this webinar. While we have this in the chat, you can feel free to click on that and fill it out. We do have a Q&A session now. So we're going to take this slide down and we're going to just go through some of the questions that we've gotten from many of you in the chat. So one of the questions is, what are some of the important differences for clinicians to keep in mind about suicide prevention when you're working with clients with FEP or individuals with clinical high risk for psychosis, compared to suicide prevention with people with, say, other mental health conditions?
Mhm. Yeah, that's a really great question. I think it's really important, like we tend to have established clinic-wide screening and assessment procedures. Everybody who has an intake comes in, we do this screening tool, or we use this assessment approach. And often these things are standardized. That's a good thing. But what we've really found when working with folks at risk for psychosis is that many of our standard measures do not apply. And so, if they are experiencing traditional suicidal symptoms where they are thinking of ending their own life, they may disclose on our suicide screeners. But unfortunately, when it comes to this risk for unintended self harm, they don't think they're suicidal. But they may be at risk for life threatening behavior. And so we've really needed to evolve our screening approaches to ask more questions about psychotic symptoms and experiences they may have had, to ask more questions about the potential for unintended self-harm and others' perceptions of their thoughts and behaviors, and really to focus on relationship building so that people feel safe to discuss these things with us. Sometimes these are rather secretive behaviors that they've never shared with anyone yet. Things that they're very frightened by or very concerned about. And they don't know if we're safe to discuss these things with us. And so, really taking that time when we're getting to know somebody, coming into our clinic to build that relationship and address these things during our assessments in a sensitive manner is vital because if we don't know, we can't help. None of these interventions or monitoring approaches are going to work if we don't know that this person may be at risk. And so that relationship building and focus on initial assessment in a more nuanced, flexible manner is really going to be vital.
Very helpful. I think there are a few questions, specifically as you were mentioning unintentional self-harm. So one question is, can self-harming behavior lead to suicide? And also relatedly, how do you have this open dialogue? What are some examples of ways you can open this dialogue with someone who's exhibiting habitual self-reported unintentional self-harm or attempts, but they deny all suicidal ideation?
Yeah, so much like the boundary between non-suicidal and suicidal self-injury can be blurry for many individuals where their intent might be ambiguous. It is absolutely possible that behavior could move between the realm of intended or unintended self-harm. Um, Really Again, we want to take a client-centered approach. So when I'm discussing these things with folks, we want to be using their words. We do not want to assume that a behavior has a particular intent. Very often these are tied to either delusions that they're experiencing or hallucinations or other psychotic symptoms that they're experiencing. And in the same way that, it can be challenging to immediately challenge those sort of things. We want to meet our clients where they're at. So if they think that, they're going to be fine if they jump off a building because they can fly, I'm not going to jump right in and challenge that, but certainly I'm going to want, like getting to the challenging of, whether or not they can fly may take a little bit of time. That may not be something that's going to change in that first session, but it's going to be important that we're putting things in place like safety planning, or other, interventions in place that regardless of why they may engage in this behavior, there is a concern for safety. So I try to focus very much on safety. I try to focus very much on the behavior itself rather than, what may be driving the behavior or the beliefs about the behavior. And again, just, having a frank conversation with folks about the potential consequences or, like how they perceive the behavior. Again, we don't want to come in with our assumptions. We don't want to come in with our beliefs leading the way. Certainly, we need to be focused on safety, but we want to be meeting folks where they at with their understanding of their experiences, so that they can move at their own pace in terms of that. I think that answers the question.
It's great. There are a couple of questions specifically on assessment. So, are there recommendations for improving assessment approaches for individuals with clinical high risk for psychosis or with first episode psychosis? And also, are there evidence-based screening assessments for unintended self-harm?
Mm. Well, to the unintended self-harm point, we are working on it. In the adaptation that we did for coordinated specialty care, we created a modified version of the CSSRS that also included some questions about unintended self-harm and how to assess that, both in like our initial meetings as well in an ongoing manner throughout treatment. So those are not available yet, but we're currently looking at the validity of those approaches. I think that's going to be a really vital area of making sure, like folks tend to rely on standardized screening tools. And if it's not, if we don't ask, we're not going to know. We've been very well trained to ask the suicide question and maybe not as well trained to assess these other areas, and so integrating that's going to be really important. The other piece is that screening in general relies on disclosure. And that relies on the client being willing to disclose, which sometimes is problematic when a person is feeling paranoid and unsure if they want to be there. It also requires them to be able to disclose. They need to have enough insight to recognize that this behavior is dangerous. And so this is really where our comprehensive risk assessment comes in. If we are aware of psychotic symptoms, if we are aware of the contents of delusions or the way they perceive their hallucinations, we have a better way of understanding what's going on for them. If we know what's going on in their lives in terms of historical risk or current family situations or upcoming stressors, we can potentially anticipate that a crisis might be brewing. These are going to be really vital because these clients may not necessarily come in and disclose suicidal thoughts. One of the things that we really learned from our work was that many times clinicians perceived that a suicide attempt was out of the blue. But when speaking with clients, it wasn't out of the blue to them. These experiences had been building over time, and they did not feel comfortable speaking about it in treatment because they were afraid, or their symptoms made it feel as though, external parties would find out or something, and so we need to, again, really build that relationship. When folks feel trust with their clinical team, when folks feel supported and connected to their clinical team, they feel safer to talk about this stuff. And so, sometimes suicide prevention is being that warm, empathic person in the room, the person who listens, the person who feels safe. Because then we can learn all of the, like there's nothing magical about assessment. It's really just being able to learn the information we need to best help our clients. And that may be to help our clients achieve their goals, but that's also to help our clients recognize where maybe there's some warning signs that they could be unsafe. And only that comprehensive approach in an ongoing manner is going to give us the information that we need to really work with them.
Right. You did mention multidisciplinary teams. And
Mhm.
so when you have clinical high risk for psychosis or first episode psychosis, multidisciplinary team environment, what are the roles that the other providers that are not the primary clinician, how can they work to help in suicide prevention, specifically like supported employment specialists or peer specialists? What are things that they can do or what role do they have in suicide prevention?
Yeah, that was one of the, I can speak most intelligently about the On Track program that was developed here in New York State. That was one of the things that was really vital to our development of these adaptations was that sometimes it felt as though the burden of suicide prevention only fell on the primary clinician. You had to do the screening and the risk assessment, and other team members had vital skill sets that they could contribute, and often new information that maybe the rest of the team did not. And so it was really important for us to think about how could we function to have team meetings be an opportunity to share information so that more informal risk assessment was something done as a team rather than, everybody had information to contribute about what was going on with this client. So making sure those risk assessment discussions were happening at team meetings. Certainly the role for prescribers, being aware of this risk might mean switching which medication you use. We know that things like clozapine have anti-suicide properties, so maybe that would be a different choice you could make, or switching to things like long-acting injectables that otherwise maybe were not on the table. So we had some specific recommendations for providers. In terms of our employment specialists and academic specialists, really framing their goals as reasons for living. So often folks are coming in feeling hopeless, like they've lost the opportunity to achieve their dreams, like that had been robbed by their diagnosis or their experiences. And we know that that's not true. People live wonderful, fulfilling lives. And so really putting those things in the context of suicide prevention, letting them know that like there is hope, there is recovery, it's possible, and here's how we do it. Really is in the wheelhouse of these types of specialists. They're already focusing on building lives worth living. And then certainly the vital role of our peer specialists who have been there in the trenches, who have experienced our healthcare system, who have experienced these kind of symptoms, and not only live to tell the tale, live to thrive, are such inspirational stories of hope, and such vital sources of support for people, both in terms of instrumentally navigating the system, which can be hard in and of itself, but also just forming those social connections. Sometimes we can both be the most amazing clinician in the world, but if we haven't been there, sometimes it hits different coming from somebody who has. And so, yeah, really a huge focus was just how can every member of the team bring their strengths to suicide prevention? And that way we can, like, have that be infused throughout our entire model.
Right. So, talking about members of the team, one of the questions is, can you speak on how we can improve and tap into the family-focused supports and how to integrate family care in prioritizing educating the family to support the individual during this time?
Yeah. So, one of the things that On Track does incredibly well is really this focus on family and support of others. So, this could be family of origin, this can be family of choice, but just this recognition that nobody's an island. You need support, particularly when dealing with scary things like psychosis. And so helping families by creating psychoeducational materials that are developed for family members, support groups for family members, making sure that they know how to support their loved one, what things to do, what things not to do. We have very active shared decision-making conversations with all of our participants. Family involvement doesn't need to be all or nothing. A lot of times folks are fearful, if mom participates in treatment, does that mean she knows everything? And so really using approaches like shared decision-making to think about what's appropriate for disclosure, what's appropriate for involvement in terms of different type, could they be involved in means reduction? That doesn't mean they have to be involved in all of your treatment, and having that be an ongoing conversation as different supports provide services throughout their lives. Maybe if they're not comfortable with that in the beginning, maybe they become more comfortable with that as relationships strengthen or change over time. So really making sure that we maintain that client-centered approach where their decision-making and autonomy is paramount, but recognizing that they need support. And in order to best support their loved one, family and support of others often need some help too. So yeah, as much as we can provide that safety net, that is really going to be the best for everybody.
Great. Thank you so much. I think that's the last question we have time for. If you all attending the webinar are able to fill out the feedback form, we'd love to get your feedback. And the slides will be made available and the recording will also be posted on SAMHSA's YouTube channel. And I just want to say thank you so much to Dr. Labouillet for such a rich discussion and really great information. So thank you all so much for joining us today, and I hope you have a great day. Take care. Bye-bye.